Thank you, Danielle, and I would like to first welcome all of you here with us tonight. Well, it's my 12th year doing this series. This is actually the 30th year of the series. And so I'm indebted to Dr. Chris Amundson, who is the founder of this series and a mentor of mine who works here at Pacific Clinics. And so we're, again, just delighted to be able to do this every year. And I like to think of this journey that we're on over these next 7 weeks is really about two things. First, it's going to be about education, because we want to provide you with the state-of-the-art education about different mental illnesses and about their treatment, and certainly all along the way about how, as family members, you can best help support your loved one. The other side of it, though, is I hope this series is also about hope, because with education can come hope. When we can understand what's going on, we can bring hope to the lives of folks with mental illness. When we can educate our community, we can help reduce the stigma that exists around mental illness. My hope is that someday we look and we talk about mental illness much in the way today we talk about cancer. 20 plus years ago, cancer was a word that was just whispered. We wouldn't want to talk about it, bring it out in the public square. We're in the process right now with mental illness of trying to do that same thing. Make it okay to talk about in the public square. And we can bring it out and we can talk about it because there's no shame around having a mental illness, having a family member with a mental illness. So this journey is really going to be about education and hope. And so over these next 7 weeks, we're going to talk about bipolar disorder, depression, schizophrenia, post-traumatic stress disorder, and then we're going to devote the whole entire final week just helpful roles and skills for you as family members. Regardless of what the mental illness is, just helpful tools, helpful skills that you can bring in best trying to support your loved one. So that's kind of the overview of where we're at, where we're headed over these 7 weeks. And again, my hope also is that you'll experience this. So rather than making it an academic lecture, there'll be very little jargon and technical terms, but more just down to earth, how to understand this stuff, and how to put it in layman's terms, and how to make sense of it. And to really help me do that along the way, there will be some folks dealing with mental illnesses. So for example, we're going to start with bipolar disorder this week and next. And so next week, a lovely young woman named Erin is going to come. Erin is a woman with bipolar disorder. She's now also a teacher. And she's married about approximately 2 years to the day. I was impressed 2 years ago. She literally came, because of her devotion to this work, the week of her wedding to come and speak to this group. So it would be a great gift that we have next week. And as we go forward with schizophrenia, there'll be at least probably a couple of young men coming in to talk about their experience with schizophrenia. And then in our final week, we talk about families. We'll have a panel of folks from NAMI to be able to kind of share their experience. So again, taking it out of the book and trying to make it fit your life and your experience. The other part of making this user-friendly is I want to say to you that much of what you may hear tonight and throughout this series hopefully will apply to your loved one. And hopefully it'll fit and it'll make sense. And rather than trying to fit your loved one into the textbook, so to speak, hopefully you'll take some of this information and apply it to them. Some of what you hear may not apply to your loved one. So don't try and force it to fit. You can let go of that, discard that part. But take the parts that do seem to really fit and see how they might best apply for your loved one. Just a little logistics as we go forward tonight. As we get close to 8, I'll take a break, about a 10-minute break for us, just to give you a little stretch. We'll come back. Towards the end, I'll save lots of time for just questions and answers. So we'll have some discussion around it. And let me see if there's anything else housekeeping-wise. I think that's probably about it. So what we're going to do is we're going to go forward and talk and get inside the world of bipolar disorder. As we mentioned earlier, this series is co-sponsored by NAMI and Pacific Clinics. And tonight we have a third co-sponsor, and that's the Bipolar Bears. These are the bipolar bears you see here. 2 of them sitting out there on the iceberg. One of them very excitedly says, "Come on, Carl, let's go chase the seals. Come on, Carl, let's go. But there's poor Carl, just kind of sitting there like a lump, right? Carl's not doing too well. And this is what we're going to see tonight. We're going to see these two worlds that folks can live in with manic depressive disorder or bipolar disorder. The highs of mania, the excitement of mania, the lows of depression. And actually, just as a side note, there is a support group called the Bipolar Bears. So if you go out and you Google that, you'll see a support group for folks with bipolar disorder called the Bipolar Bears. So as we get started with this, I want to kind of backstep and put this in a little bit of context and talk about moods. So in the big picture, moods. What are moods? We all have moods, but what are they? Moods, a real simple definition is moods are the tone of our internal state. What's the tone of our internal state? Are we happy, are we sad, excited, anxious, nervous, disappointed? What's the overall tone of that emotional state? And what that mood does, right, is it colors our perception of ourself, of others, and of the world. So the mood, right, those emotions, the emotional state, and again, it's going to really impact how we view ourselves and the world. And I just put that first out there, and I just want to differentiate our moods, which we're going to be really honing in on tonight, from our thoughts. Our thoughts. What are our thoughts? Well, thoughts are the way we put together ideas and associations. Right? Thoughts are there's the form in which we think, way we think. It's the form in how I think, how I process information. That's part of thoughts. And then there's also the content of my thoughts. What is it I'm specifically thinking about? And I put those out there, this idea we have moods and we have thoughts, because when we start thinking about mental illness, there can be a lot of overlap. There's a mood disorder and a thought disorder. There's depression, bipolar disorder, there's schizophrenia. There's a lot of overlap between those two conditions. And so it might be, well, how do we distinguish between the two? Certainly folks who have schizophrenia have a lot of difficulty with their moods. Folks with bipolar disorder will experience difficulties in their thinking. So how do we tell these two apart? And the essential distinction that I want to give you is that bipolar disorder is a mood disorder. So predominantly we're talking about a disruption in moods. Whereas schizophrenia is going to be predominantly a thought disorder. So the primary disruption is in thinking. It may sound pretty straightforward in saying it that way, but if we go back 100 plus years ago, late 1800s, without any treatment, without any medication to get these illnesses under control, a lot of times, how can we differentiate? And back at that time, that's where the term manic depressive illness was coined by the German psychiatrist Emil Kraepelin. And he differentiated that from what was called dementia praecox, what we now call schizophrenia. And again, the essential distinction was a mood disorder and a thought disorder. And I just got to say that at the outset, because so often when you're going through that maybe turmoil, trying to get the most accurate diagnosis, one doctor says schizophrenia, one says bipolar disorder, another one says schizoaffective disorder, which is sort of a hybrid between the two. I just put this out there to help you distinguish that, the essential distinction in that mood versus thoughts. So as we think about coming back to moods, we can see I've got a nice sort of a scale here. And most of the time, most of us are going to live in that green realm. Our moods are, quote unquote, in that normal range. You might call it euthymic. And we'll vary within there. We'll have our ups and our downs in our day, or in our weeks. We might get the blues sometime. But if we go down further is where we're going to get into more significant depression and clinical depression. The other side of it is where we're going to be going up into what we're going to call hypomania and mania. And we'll be going into these in more depth as we go further tonight. That's going to be on the high side. Beyond happiness, beyond excitement, we work our way up. Now as we think about moods, we can think about these as distinct states, but it might help us think more about this as a continuum as we shift. Because in reality, we don't usually think of ourselves as in a particular place. In physics, when they try to just explain light, they have these debates. They have particle theories and wave theories. One They'll have particle theory, which say light is made up of these particles. Others which talk about waves. And they're both correct, at least the current state-of-the-art understanding is both of those things are ways of understanding light. So in moods, we might think of the same thing. I'll talk about what is mania and what is a manic episode or manic state. We'll talk about depression, what is a depressive state. But usually what we experience is we kind of gradually work our way up into these places and gradually work down. And so understanding that as on a continuum is a good way of thinking about it. When we get into bipolar disorder, obviously the stakes are much higher. Because in day-to-day life for someone without a mood disorder, again, we're going to stay in that green area there, that normal realm. Whereas in bipolar disorder, we're going to have the real swings. So it's kind of like the difference between going on the kiddie coaster at your church carnival and going on the Colossus at Magic Mountain. Right? One's going to be a little fun, but not going to be too dangerous. The other one's going to scare the daylights out of you when you go down those big slopes. So as we get into understanding this, think about that in that way that we're looking at extremes on a continuum that we all experience, but in a much more extreme way. To give you a brief introduction, bipolar and related disorders. I put that term up there because the new DSM-5. Now, the DSM is basically the Bible or the Encyclopedia of Psychiatry, if you will. It's where all the different diagnoses are listed, the criteria for them. So it's the book that's used to describe all of that. And a new volume, the 5th edition of the DSM, is just out this year. And the category of bipolar disorders, that chapter is now called Bipolar and Related Disorders. And what can we say about these disorders? First, they're biologically based brain illnesses with strong genetic factors. So right out the gate, I want to tell you these are biologically based disorders. In years gone by, we might not have thought that. If we go back 20, 30 years, certainly beyond that, 50 years, pretty much all psychiatric disorders were seen as in the same light. And that is childhood, family, dysfunction. That was the cause of psychological issues in adulthood. Primarily, moms, you got the blame for everything. You were the cause of any disorder imaginable. So it's kind of hard to get things right, because you can do it one way, you end up with this, another way, you end up with that, you're still in trouble. Now, while moms can still do a lot, can still do some good and do some damage, we know that a disorder like bipolar disorder is not the result of early childhood upbringing. It's not the result of some poor decision made by the person, made by parents. These are biologically based disorders, strong genetic factors. We'll talk about that more as we go on tonight. And the hallmark here, we're talking about a mood disorder characterized by the mood swings, the highs of mania, the lows of depression. We're going to go into those more in depth as we go forward. Important to know that bipolar disorder is what we might term a recurrent disorder. What we mean by that is that 90% of the individuals who have a single manic episode will have another episode. So unfortunately, there's a lot of things in life that you make a mistake, you learn from your mistake, you can prevent it from happening again. Bipolar disorder, unfortunately, is not one of those things. It's a little too cruel to be one of those things. Now, as we go forward, you are going to hear that while there's no cure, we do know that there is recovery. And if we provide the right treatments, we can improve the quality of life for folks dealing with this disorder. And so as we go forward, having this education tonight we're going to be really honing in on understanding the disorder. Next week, we're going to get into all the different the treatment that we can do for the person, because we know that it makes a huge, huge difference now when we provide the right treatment for folks. Psychological and psychiatric disorders nowadays are becoming more specialized. If you have a medical condition and you have a heart problem, you're probably going to want to go see a cardiologist. Makes sense, right? You're not going to go to a podiatrist for a heart problem. You're not going to go to a cardiologist if you have a problem with your feet. it just makes sense, and we kind of laugh because, why do we do that? In psychology and psychiatry, it was at one point kind of one size fits all. But nowadays, again, really the past 10 years or so, more and more specialized. If it's a childhood condition, you want to make sure you get someone who specializes in childhood disorders. If it's a major mental illness, you want to get someone who understands major mental illnesses. Because again, there are different treatments based on the different conditions. And again, becoming much more specialized. So it's great that you're here tonight to get this understanding. And great that you can connect with an organization like NAMI, who can also help steer you in the direction of good treatment. Because we want to make sure you get that. Experience of the brain, experience of the mind. So it is a biologically based disorder. And so if we start looking at bipolar disorder, we might consider it as characterized by severe dysregulation. Dysregulation. Things are thrown awry, not able to be regulated well, first in the brain. And so in the brain, if we were to kind of examine and look inside, it would mean difficulty in coordinating mood regulating circuits. So the wiring of the brain, if you will, gets thrown off. Connections between different parts of the brain. For example, the frontal lobe of the brain, the executive part of the brain that organizes plans, all of that good stuff that makes us human. And then some other deeper structures, the limbic system, the amygdala, where there's this fight or flight that kicks in. We know in this disorder there's some problems in the connections between those two areas. And we can see some disruption in mood as a result of that. So again, science has really been at work in the last few decades now with the advent of brain scans to be able to look into the brain and certainly in research to be able to see this and understand more of what's going on with these disorders. So it's definitely a brain disorder. But the mind, right? The mind, how we process things, how we understand the world, how we make sense of things. What it means is that for the mind, it's difficulty maintaining equilibrium or balance in everyday life. How do I balance these moods out? How do I know what's too little, what's too much? Sometimes bipolar disorder is, Goldilocks is a good metaphor with bipolar disorder. Sometimes things are just too high, sometimes they're too low. And we want to try and find it just right. And sometimes you may have experienced that frustration that you can never get it just right with your relative. Things are always going to be a little off. There was one woman who I knew who actually 10 plus years ago helped me with this series. And she had bipolar disorder herself. She was actually back to school studying to be a psychologist. And what she said is for her, bipolar disorder was a disorder of energy. That's how she understood it, as a disorder of energy. She said, there were times when my energy in my body was too high. I would be too amped up. And when I was too amped up, I'd have to do things to help bring my energy down. And there was other times when my energy was too low, and I had to do things to try and bring my energy up. Now, in the textbook, we might describe it as mania and depression. And she wouldn't disagree with that, but her experience was that it was a disorder of energy. And I say that again just to invite you that when you are listening or talking to your relative, that you really ask them and really take interest in understanding their experience of what's going on with them in their world. And try to understand that and connect with them on that level. And oftentimes that may be an entree into working with them, because they'll see that, okay, you're listening, you're understanding, this is what's going on. You're not trying to just make me an illness. You're not trying to just pull out a textbook and make me fit in there, which none of us like to do. Right? None of us like to be boxed in that way. We want to know that we're a unique person with our own experience. Bipolar disorders are equal opportunity disorders. And what I mean by that is they don't discriminate. They exist equally among men and women, all races, ethnic groups, and social classes. So in many respects, bipolar disorder is blind to culture. Culture will play a difference in how some of the symptoms may be manifested. So for example, if someone is experiencing a real high of mania, and if they were a Christian, they might believe that they are Jesus Christ. If they were in a tribal culture, they might believe that they have, the spirits have endowed them with special gifts. So there'll be some cultural differences in how these things are played out. But in those two examples, essentially what we're talking about is the experience of a delusion in someone with mania. So again, equal opportunity. All gender, races, ethnic groups. We also know that depending on how we look at it, statistics, as low as 1.5 to 2%, as high as 6% if we want to get into bipolar 1, bipolar 2, different mood disorders, depending on who's doing the study. National Institute of Mental Health has said that every year 5.7 million adult Americans, or 2.6% of the population, will be experiencing bipolar disorder. The average age of onset of these disorders is 15 to 30, the median being about 25. Why is this? Why is this? And as we'll hear about in a moment when I talk a little bit about some gender differences, generally going to be a little earlier in men. But what's going on? We might think, what's unique about these early 20s, especially late teens into the 20s, that's going on? Well, I said before, this is a biologically based disorder. And now we know that there are certain things that just biologically happen at certain periods of time in our life. I have a son who is 12 years old. I am expecting in these next, very soon, could be any day now, his voice may start cracking a little bit. He might not share it with me, but might start to show interest in the young ladies in his class. Right? We all know this is puberty. It's a normal thing. But it doesn't just happen at birth, it happens around this age, 12 into adolescence. Right? It's just biologically programmed. The programming was there since birth, but it comes out around age 12, early adolescence. With bipolar disorder, it's the same with schizophrenia. What I can tell you about the reason of the onset is going to be in the same thing. There is a programming going on. In all of us, when we are born, our brain grows like wildfire. Circuits, connections growing in the brain. And it's just an amazing, amazing thing. And it grows all the way into early adolescence. And in early adolescence, now while the growth is going to continue on much later than that, what happens in early adolescence is a really important process to refine the brain. And that's a process called cortical pruning. And cortical just meaning the cortex. Pruning, anyone that has a garden, you know what pruning is. You get your clippers, you go in, you prune away the weeds. And what you do when you prune away weeds is you allow the plants, the flowers, to grow stronger. You're taking away that which is not essential so the essential can grow stronger. That's what's happening in our brains starting in adolescence, really throughout adolescence. There's this pruning process. So think of the brain as all these circuits growing, all this wiring growing. And imagine it almost becoming like an overgrown garden. And so we want to start pruning in there so that the important connections can grow stronger. And this is what happens in most of us, or it happens in all of us, but it happens in a healthy way for most of us. When a mental illness like this kicks in, the process goes awry. So imagine now you've got your prize-winning rose garden, and you gave your 7-year-old nephew the hedge trimmers, and you had him start going and weed. What's he going to do? There's going to be mistakes. Things are going to get tangled up. He might even cut away some of the important things. It goes awry. This is what happens in that late adolescence, and which is why we see as an outcome a mental illness like bipolar disorder or schizophrenia. So that process going awry. So that's why typically we're going to see it in that period of time. It can occur earlier. There is childhood bipolar disorder. It can occur later, later than 30. That's our kind of basic understanding of why it occurs in that time, which it does. So there are some gender differences, as much as it is an equal opportunity disorder. First, some research suggests that women who have a later age of onset have greater seasonal pattern of mood disturbance, kind of like the winter blues, that kind of thing. And a lot of that is due to lighting, so absence of lighting. 3 times more likely to have rapid cycling. We'll talk about that a little more as we go forward. tend to have more depressive and what are called mixed episodes, both depression and mania at the same time, have more co-occurring anxiety and physical health problems, so problems such as thyroid disorders, obesity, migraines, and be misdiagnosed, we'll talk about that more in a minute, be misdiagnosed with depression. Some research suggests men, again, have the opposite, have an earlier age of onset, have more co-occurring substance abuse disorders, and will be more likely misdiagnosed with schizophrenia than if it's a wrong diagnosis. The other thing I will add is that, again, and I want to make sure I'm letting you know, this is a statistics. We know about statistics. They're generalities. They don't apply to everyone. But that earlier age of onset, generally the earlier the onset of the disorder, the more severe the form of the illness for the person. Now again, that's a statistic, but generally childhood bipolar disorder will be more severe than someone whose disorder hits when they're 30. So just to be aware of that when you are dealing with this. So again, there are some gender differences with this. Great nickname I like to give bipolar disorder is the chameleon. What does a chameleon do? A chameleon can change its colors, kind of blends in with the background. And so it can look different under different situations. And bipolar disorder is very much like that. First, it can look very different in different people. So from one person to the next, bipolar disorder can seem very different. One person's mania can be different than another's. One person may have more predominant manias, the other one more predominant depressions. So it can look very, very different. It can also look very different, again, within the person. At times there's depression. At times things seem okay. Other times we're up in mania. So within that one person, we see these differences. Over time it changes. If there's substance abuse going on, those appearances now look different as well. So lots of differences there that can make it really difficult, really challenging when we're trying to diagnose, which is why it is so often misdiagnosed. To underscore that, there was a study done by the Depressive and Bipolar Support Alliance, which is, I'm going to hear more about that, especially next week, a great resource for folks with this disorder for support. They did a research study. It's from back in 2000. But what they found is that for half the people who have bipolar disorder, none of them received treatment in the first 5 years once they had the disorder. So half the people who have bipolar disorder get no treatment for it in the first 5 years when they have it. Now I can also tell you that the most significant decline, the most significant deterioration or damage done by the disorder happens in the first 5 years. So the first 5 years after onset is when we're going to see the biggest slide. When are they least likely to get help? The first 5 years. Go out a little further. For a little over a third of those folks, there was no treatment for 10 years. 10 years. Only 25% received an accurate diagnosis within 3 years. On average, it took 8 years after seeking treatment for the person to get the accurate diagnosis. After seeking treatment. So, wow, right? It can kind of blow us away a little bit. But there's lots of reasons to understand this. Just to throw out a few of them. If you have times when you're feeling really great about life and times when you're feeling horrible, and you go to see your doctor, which are you going to complain about? The horrible times. You're going to tell them you're depressed. Right? You'll tell her you're depressed. You're not going to say, there's other times when I feel really good. I feel really good. So, first misdiagnosis, depression. But it makes perfect sense. It makes perfect sense. You're out there and you are a young adult and you're experimenting with drugs. This looks like a drug problem, doesn't it? This person's high. Right? We know what that looks like. You're on cocaine. It's clearly what it is. And perhaps they are using some. Perhaps even they're not. But it just looks like that because we know that. And probably more likely than not, people are going to be more familiar with addiction than they are with a mental illness. And more likely to think that, hey, that guy's on something, than they are that, that person might have a mental illness. So that's another reason why we might see it. Part of it I'll put back on, as the professional community, perhaps not being aware or being trained in this area to understand the complexities of the disorder and seeing it. So whether we think it's depression, just an addiction, and again, over time, even with the best professionals, we can see it as one thing. We can see it as schizophrenia versus bipolar disorder. The good news about that, though, is oftentimes, even if we have different diagnoses, we're probably going to agree on the treatment. We're just seeing it from a different angle in how we look at it, the label we might put on it. So lots of reasons that play into that. But bottom line really to take away, again, just goes back to if there is something going on, to make sure you connect to get that accurate diagnosis. Try and connect with folks that understand this disorder. Be it you're a psychiatrist or a therapist, whoever that might be, to be able to work with it. Because again, this chameleon can appear so very different and so confusing. We're trying to understand it and trying to work with it. The costs of bipolar disorder are deadly. According to the World Health Organization, it's the 6th leading cause of disability worldwide. Wouldn't think of that, but bipolar disorder is. Billions of dollars every year in medical care and lost productivity, meaning in the workforce, every year, as a result of this disorder. Upwards of 2/3 of folks with this disorder are going to have a substance abuse problem. Think about it. If you're going through these periods where you were feeling really high and other times when you're really low, you're going to try and manage this. And sometimes we call it self-medicating. Right? You're going to do things to try and manage this condition. So it just makes sense. You might start out with a little bit. Have a drink or two at night just to take the edge off. Or smoke a little marijuana, kind of chill me out. I can take a little something in the morning to pick me up. Maybe it started with 7 cups of coffee, but maybe I graduated up to a little bit of cocaine just to get me going in the morning. And it goes on and on from there. In efforts, oftentimes, to manage. Life expectancy, almost a 10-year reduction in lifespan, according to the National Institute of Mental Health, from this disorder. And then, probably most sadly, up to 15 to 20% of folks with the disorder will end their life with their own hands as a result of suicide. So we know this is a fatal disorder. And we want to be serious when we address it and when we deal with it. Having mentioned that, I do want to give you a little hope. And that is, we've talked about the importance of getting in and getting that right treatment. When we do that, one study found that if we can go in and get the right treatment, that in that first year, what we're going to see is that 95% of the time there'll be symptom recovery, meaning that the symptoms of the illness we'll talk about will dissipate. We'll be able to do things to manage that. However, there's only 40% functional recovery in that first year. Meaning by functional recovery, we're talking about back into life. Relationships, school, work, what have you. The functional recovery. Now that continues on. Doesn't mean that it ends at that 1 year. But what that study points out is a couple things. First of all, the hope of when we get in the right treatment. Second of all, the awareness that when a symptom goes away, it doesn't just mean I can get back on the horse. There's a wonderful analogy, right? You fall off the horse, you get back on. Right? Popularly, makes sense for many things in life that works. With these disorders, it doesn't always work that way. When we talk about recovery next week, we'll go into that in a little more detail. But the takeaway idea here is that just because the symptoms seem to have abated, doesn't mean the person's back to 100% in terms of their functioning. You still have to take steps forward with that. And hopefully help them be able to do that. Because they may just want to get back on the horse. And it makes sense. I'm not like this anymore. I'm not depressed. I'm not manic. I'm fine. I'm ready. Let me go forward. And sometimes if we jump too fast, they go basically out of the hospital and back to a full-time job in 3 weeks. Oftentimes it's a setup for failure. So we try and space that out a little bit. Of course, working with the person at their pace as well to make those things happen. Just so you know, this disorder isn't just a hidden disorder somewhere. There are many famous folks who dealt with this disorder. Actually, during the break, I'm just going to run a slide show that shows lots of folks who have bipolar disorder. But just to toss out a few names now, all folks who've identified with the disorder. Patty Duke, the actress, a wonderful book called The Brilliant Madness, which is her autobiography, and then co-written by a doctor who's explaining what's going on during that time. So it's a wonderful, wonderful book. Carrie Fisher, many of you probably remember her as Princess Leia, right? But she experiences bipolar disorder, and she actually is one that can put a good sense of humor on it as well. So, for example, Carrie Fisher said, "Losing your mind is terrifying, but once it's gone, it's fine, because there's no part of you that knows the rest of it is missing." So she puts a little humor into her experience of the disorder. Handel, the great composer, he wrote that wonderful work called The Messiah, and he did that in 23 days, the entire piece. That's productivity for you, right? Mark Twain. Twain said, "Life is a nightmare confusion of spasmodic and fleeting delights, ecstasies, and exaltations, high, interspersed with long-drawn miseries, horrors, and despairs." Great definition of bipolar disorder right there. The highs and the lows. And so we see this exists everywhere, throughout our culture. To mention that the types of bipolar disorder, essentially two different types of the disorder. Bipolar 1 and bipolar 2. The main distinction in bipolar 1, you're going to see full-blown manias. In bipolar 2, we're only going to see hypomania. Remember back to that slide I showed with the moods. Basically, it's saying in bipolar 2, we're only going up the scale on the high side a little bit. In bipolar 1, we're going to be going up into full-on mania. Generally, if the high has led to a hospitalization, you're looking at bipolar 1. I'll go into it in more details when we talk about mania in a few moments. In that new DSM-5 that I mentioned, there's bipolar 1, there's bipolar 2, and there's something called bipolar disorder, NED, which is basically just, NED is not elsewhere defined. It's basically the little catch-all. It doesn't quite fit into one of the other categories neatly. We can use that. For practical purposes, just throw it out. You don't need to remember that. But it's just wanted to mention those are the three different ways it's characterized in the DSM. One of the nice things about the new DSM is that it's going to allow us to really rate this disorder along a continuum of severity. So what I was saying before about the idea that we look about this as a continuum, the new DSM is going to allow us to do that in the way we rate it. So hopefully that'll be nice. We'll see if that has any practical applications. A word about bipolar 2 disorder. In bipolar 2 disorder, the depressions are dominant. The depressions are dominant. So, a study looked at a number of folks with this disorder over the course of the year. How many days were they in a particular mood state? And they looked. And they had it categorized as in a hypomania, in that green kind of normal bar, which is called euthymia, or in a minor depression, or in a more severe depression. With bipolar 2, what they found is that a little less than half the time, 43%, they were doing pretty well. They were doing okay. About the same amount, well actually much higher, a little over 50% of the time, they were in either a minor or major depressive mood. And only 2% of the time were they up into hypomania. So really, in an everyday practical sense, it looks like depression. And it looks like a depressive disorder. And probably a lot of the counseling or therapy we'd be doing would be addressing that depressive side. Probably very little of it to have to address the hypomanic side. However, what is important in getting this diagnosis accurate is that from a medication standpoint, We want to know if there are those hypomanias. We want to know, does this person have a propensity to go up into hypomania? Reason being that if we just give an antidepressant medication to someone with this condition, we can trigger a full mania. That's a danger, a possible danger. Not always, but we can do that. And so that's why we want to be aware, if this person is bipolar 2, it'll dictate the medications we might use for them, as opposed to somebody who's just dealing with depression alone. So again, bipolar 2, the main takeaway, mostly depression, very little bit up into the hypomanic side. So let's look on the high side. Let's get back to that scale. What we're going to be looking at here is really going to continue and talk about these symptoms as we go up to hypomania, mania, and at that high point, what we'll call a psychotic mania. And just about half the folks who go into full mania are going to experience a psychotic mania. And what I mean by that is they're going to experience either hallucination most commonly of voices, hearing things, that less likely than delusions. The most common psychotic symptom in mania are delusions. Delusions are those fixed false beliefs. So a delusion might be, again, on that high side. I believe that I am Jesus Christ. I believe that I can jump if I can fly. I believe that I'm just the greatest thing to walk on this planet. The other type of delusion that's very common is a paranoid delusion. I might believe that the CIA has implanted bugs in these lights because they know I've got information that they want, and they do that. Or I might believe that you are poisoning me. So I come down to dinner, you've been poisoning my food. So those are the delusions that can exist. Again, pretty much only on the real high points of mania will we see those in someone with bipolar disorder. Let me read you a patient's experience. This comes from K. Redfield Jameson, who back in 1990 really first wrote the book called Manic Depressive Illness. Really the first kind of changed the field quite a bit. She put together all sorts of research information. It was pretty much a state-of-the-art book in terms of understanding the disorder. And what she says in this book, there's a particular kind of pain, elation, loneliness, and terror involved in this kind of madness. When you're high, it's tremendous. The ideas and feelings are fast and frequent, like shooting stars, and you follow them until you find better and brighter ones. Shyness goes. The right words and gestures are suddenly there. The power to seduce and captivate others, a felt certainty. There are interests found in uninteresting people. Sensuality is pervasive, and the desire to seduce and be seduced irresistible. Feelings of ease, intensity, power, well-being, financial omnipotence, and euphoria now pervade one's marrow. But somewhere this changes. The fast ideas are far too fast and there are far too many. Overwhelming confusion replaces clarity. Memory goes. Humor and absorption on friends' faces is replaced by fear and concern. Everything previously moving with the grain is now against it. You are irritable, angry, frightened, uncontrollable, and enmeshed totally in the blackest caves of the mind. You never knew those caves were there. It will never end. Madness carves out its own reality. It goes on, and finally, there are only others' recollections of your behavior, your bizarre, frenetic, aimless behaviors. For mania has at least some grace in partially obliterating memories. Euphoria or irritability. Again, we're going up on the high side. Things are getting exciting. Got all these ideas, it's wonderful. Euphoria, the mood becomes euphoric. Beyond happy, everything is wonderful, everything is great. Or it could be irritable. I'm going to come back around to that, and you'll understand how it could also be irritable. Hallmark symptom of mania, racing thoughts. racing thoughts. They're just going super fast. Now, I'm going to guess that most of you in here can remember what a record player is. Yeah? I don't know when the last time I've seen a record player is, but I remember having a record player. Right, I grew up with a record player. And if you have an album and you put it on the record player, you probably remember, what speed do you play an album at? 33. 33. Someone's dating themselves. 33 to play an album. Yes. You play it at 33, and it sounds the way it's supposed to. Everything makes sense. There's harmony. You can hear the lyrics. It's going at the right pace, right? That's what we want to see. If we take that album, but we turn it up to 45, maybe you do this just to get a kick, see what it sounds like. I always thought it turned every singer into the Chipmunks, right? Everything just started going at a higher, the pitch was higher, it went faster. Now, at 45, you can still make out the words. It still made sense, but it was a little bit off. If you then turn it up to 78, then what happens? It's just going and going. You can't make sense of anything. Now it's the Chipmunks on speed. You can't make sense of anything that's going on there. This is the experience of racing thoughts. When our thoughts are at that normal pace, it's like 33 on the album. Into hypomania, we're up to 45. In hypomania, the thoughts can still make sense. We can still follow it. We get up to 78. Mania, we can't follow it. We're not there. The person is just going. It makes sense to them, but it doesn't make sense to everyone else. That's how fast their thoughts are going. When they're going this fast, one of the other symptoms they'll experience is called a flight of ideas. Because the brain's working so fast, they've got one amazing idea. A few minutes later, they've got another amazing idea. It's sort of like Grand Central Station. A train takes off every 5 minutes in a different direction. And that's what it can be like with mania. New great idea, then 5 minutes later, wait, where'd you go? Oh, now you're going this way for this other idea. A flight of ideas is what we call that. Well, I've got all these ideas, my thoughts are going fast. I can't get them out fast enough. My speech is going to become pressured. It'll be rapid. I've got all these wonderful ideas, I've got to get them out. You got to understand me. I've got to get them. That's a pressured speech, rapid speech. It's going to happen. Again, my mouth can't keep up with my brain. It's going to go out that way. Part of this high of mania, grandiosity, grandiose thinking. Right? All these ideas I've got, they're wonderful ideas. Wonderful, amazing, amazing ideas. Carrie Fisher, what she said is, every idea is like an edict from the Vatican. It carries that weight of importance, right? Every idea is that important to her. As we go up into hypomania, in hypomania, you know, I've got ideas, and you've got ideas. My ideas are better than your ideas. I'm in hypomania, kind of moving up there, a little bit that high. We go up into mania. I've got ideas. You don't have ideas. I just have ideas. Mine are great. Just go along with me. Kind of get out of my way and go along with me. That's what's in mania. Right? Put these together that we've got so far. My thoughts are racing. Right? Lots of different ideas. And they're amazing ideas. They're not just ideas, they're amazing, grandiose ideas. I'm trying to get them out there. I'm going to try and bring them out to you. Right. Now, I was in this really great mood because I've got all these wonderful ideas. But what happens when I'm trying to tell you these ideas? Or I go out in the world and I'm trying to share these ideas. I walk into that Fortune 500 company and I'm going to take them to #1 if they would hire me. Because I've got these great ideas. But they don't hire me. Or you don't just support my ideas. Now that euphoria becomes the irritability that you heard Jameson talk about, right? Because I've got these ideas. I'm working it. You're getting in my way. The world is getting in my way. It's irritability, right? I don't have a perspective that, oh, other people have different ways of viewing things. You have another idea. That's not there, right? I'm self-absorbed in this space. So that's where the irritability can come in. Physiologically, decreased need for sleep. In a manic state, persons can go days without sleep. and they're not tired. They're not tired. Sometimes some of this, when we're anxious, anxiety and mania at times can look very similar. When someone who's anxious, they're going to feel tired. They're going to feel tired. Anxiety is draining. In mania, that energy is there. Days on end without sleep. Or just sleep a few hours a night and go on for weeks like this. Now at some point, we'll get a crash. But as we're going through it, again, it can go for a very long period of time, that little sleep or times for periods of even no sleep. The energy is still there. So amazing amounts of energy with this. And that symptom of the increased energy is a new one to DSM-5. We've always known it anecdotally, and we've kind of just maybe lumped it with the decreased need for sleep, but now it's actually in there as a new symptom that we're using. Increased goal-directed activity kind of just plays along with what I've been talking about. Got these ideas, I'm focused, grandiose, I want to pursue them, and so I am going to focus on them. I am going to go with it. Well, I'm easily distractible as well. So a lot of distractibility here. And then, sadly, at this high place, we'll see a lot of reckless behavior. A lot of reckless behavior. Again, some of that ability just to connect in the world isn't there. One of the things that she said, sensuality is pervasive. So I'm going to get in my sports car and I'm just going to go along Mulholland about 90 because that's exciting. That's really exciting. It's pretty darn dangerous too. I'm just enamored, right? Sensuality. I'm going to go out, I'm going to meet people. Promiscuity, I don't think twice about promiscuity because it's just exciting. It's exciting. On the other side, when there is pain in all of this, again, we heard about the statistics around suicide. So behaviors that can lead me into that realm as well. So a lot of very reckless behaviors. Oftentimes, this is one of the symptoms that you as family members will often diagnose when the person does not. I know, for example, one time, the only reason this came out, the person I was working with, is he told me he got a new car. Oh, tell me about your new car. Great, great, great. And he was telling me all about it. And he said, and somehow it came out, I said, yeah, it's my third car this year. Third new car this year. What happened? What happened to the other two? Got in an accident. It's like, okay. So then it kind of painted the picture of what was going on in another way, right? So, always good to get to know folks. Some of the exciting things about their life, like getting a new car. You might learn some things. So a lot of reckless behavior in here. So all these symptoms, again, just coming back to that idea of we're working up a scale, so to speak, that continuum from normal, hypomania, mania, psychotic mania, if you will. So we got the moods, if we talk about moods, right? In hypomania, there may be some of that mild euphoria. Some lability. Lability is when things kind of fluctuate a bit. But when we go up higher into mania, again, the real euphoria, perhaps the real irritability. It goes even beyond that in the psychosis. The thinking, because even though it's a mood disorder, it's going to affect the thought process as well, right? So in hypomania, again, my thought process is going a little bit faster. I'm getting expansive. I'm still coherent. I may go off on tangents, but I'm still coherent. You can stay with me. I get into mania, right? That flight of ideas. My thoughts are now disorganized. You're not able to follow them and make sense. And you get into psychotic mania where we get maybe some delusions. Maybe we get just real loose associations is another term. It's when a person really, the way you'll see that is when they're really bouncing from one thing to the next, but in their mind it makes sense. Behaviors, got in hypomania, going at a faster pace. You know, in some ways if we could bottle hypomania, it'd be great. We'd get a lot of work done in our work day. We'd go out and we'd exercise because we have the energy to do it at the end of a work day. You know, we'd probably like it if we could bottle it without the side effects. Right? In mania, behavior is very accelerated, fast-paced, pressured speech. In the psychotic mania, the real highs, it's frantic, it's erratic, unpredictable. So again, we're seeing it kind of working its way up there. Again, Carrie Fisher. I consider mania to be a bank error in my favor. She goes to the bank, she finds, oh, look at this. Someone just put $10,000 in my account, great. I'm gonna go out and spend this. Right? What happens to the bank error? Comes back to get you, right? Sorry, we did this, you owe us that $10,000. What happens in mania? You go out, you spend it, you end up in the hospital. It crashes. So she was right on more than one account when she said that to us. Mania is like the rocket taking off, because if we look in the brain, we're going to see that. A quick scan of a brain in a normal mood state and one in mania will highlight this. This is what is known as a SPECT scan, looking at blood flow activity in the brain. And what you want to see under an activity, on the left side, what you'll notice is, can't see it too clearly, but up here, this will be kind of in that frontal lobe region. We want to see some concentrated activity up there. Because that's where we're going to plan, organize, think, problem solve. If I took a brain scan right now, I'd see something like this. You're taking information, you're probably applying it to your relative, what fits, what doesn't fit, and you're using that. In mania, what are we seeing? Yes, the brain on fire. Sometimes people say that, it feels like my brain is on fire. I can't turn it off. The subjective experience will describe this, that when we look in the brain we see. There's just lots and lots of activity there. And we'll see that a lot of areas are working too hard, but actually what we'd also see is that other areas aren't working hard enough. And again, it's just that experience of like the brain on fire for the person. Okay, well, welcome back. We're going to start our second half, and we're going to look at the low side. And as I start this, I'm going to just briefly go through the depressed side and just remind you that we're going to spend a whole week of this series talking about major depression. So if this is something that you're more interested in, please come back for that week and we'll be talking much more about it. But again, we're looking at a continuum. We go from that normal state to the blues, minor depression, down into major depression. First, the distinction between the blues and depression. You know, the blues is something that we all experience. Blues are a normal reaction to a life event. And unfortunately, what can happen is, because someone has experienced the blues, they might tell someone with depression, you know, I've experienced this too. You got to pull yourself up by your bootstraps and just try harder. You can do this, you can get over this. Because with the blues, oftentimes doing things like that can really be effective and work. Depression, not so much so. So what's the difference here? You know, with the blues, primarily just my moods, I'm kind of down. A few minutes, a few hours, maybe a few days, going through something. Depression really affects multiple domains. The moods, the thoughts, the body. The blues are temporary. Depression is persistent. The blues rarely would lead to suicidal thoughts or actions. In depression, we know it's a common symptom of the disorder. When we go through the blues, what do we really need? We need time. We do some things to help us cope. Some support's nice. When we're experiencing clinical depression, we're going to require some professional help if we really want to tackle it, be that through medication and or psychotherapy. And one of the real key ways of making this distinction that I like to give is that when I go through the blues, I have this experience that there's just something wrong. You know, this thing's going on at work, it's driving me, you know, bonkers. Or, you know, I'm going through a grief process of losing somebody. So I know there's something wrong going on. When I have depression, there's something wrong with me. It's an internal sense. I have a sense of guilt or shame. It's that there's something wrong with me. So that experience of something wrong is not out there, but inside. And again, it makes it much more challenging to address it when we're dealing with that. A working definition of depression is that it's a state of existence marked by a sense of being pressed down, weighed down, or burdened, which affects the person physically, mentally, emotionally, spiritually, and relationally. So it affects the entire person. And when I think about the symptoms of the disorder, rather than give you a list, what I want to do is highlight these different areas and see how we can see the symptoms affecting the entire person. So if we look at the physical, what are we going to see? A lack of energy, fatigue, a change in appetite or sleep. And it can go either direction. Eat too much, eat too little. Sleep too much, sleep too little. So we're looking for a significant change in appetite or sleep. And again, we can go either way with this one. A restlessness or a lethargy. Restlessness or lethargy. So physically, we're going to see depression in the body. Mentally, the thinking, indecision, or concentration, or focus, as well as those suicidal thoughts that come in. Down the bottom, emotionally, the experience of having a depressed mood. I no longer enjoy things that are pleasurable to me. I don't need fun anymore. Even my favorite hobbies, I don't want to do. Inappropriate or excessive guilt and shame, and that sense of hopelessness. In the middle, spiritually where I have that sense of meaning or purpose in my life. Perhaps I experience more despair. If I'm religious, maybe I experience a disconnect or abandonment from God. So on that deeper level, I experience, again, that something is wrong with me. There's a disconnect. And then relationally, a hallmark in depression is isolation. But also, unfortunately, we see a lot of tension in relationships. Right? Partners who are frustrated. Right? Parents who are frustrated. Siblings who are frustrated. Whoever it might be. Because that person just won't kind of get up and do things. Won't get out there. Right? You're not trying hard enough. It could be those misconceptions that go on with depression. And so see this as affecting the entire person. And know that no matter where it comes from, where it starts, because really in some ways it could almost start anywhere on that cycle. No matter where it starts, once depression hits, there is this imbalance in the brain. So again, let's go back into the brain, look at a little picture. When we're looking at, on the right, that healthier brain, recovered brain, the bright colors indicate high levels of activity. The dark colors, the blues, low level of activity. And I really want to just highlight this top portion here. This is kind of a top-down look. So again, up here I've got the frontal lobe. And again, lots of activity going on there because I want activity in the frontal lobe. That's the uniquely human part of me, the executive part. I want activity there. In depression, we're going to see less activity going on there. Still some, but less. So we're not able to process as quickly. We're not able to concentrate so well. Not able to problem solve. All those things are getting in the way. And so once it hits, we'll see a physiological component to depression. So I just want to touch on that part briefly again because we're going to spend a whole week talking about that. But this is the other side, right? The other side from the mania. Now with bipolar disorder, it's really puzzling. And there's many things that, if it wasn't bad enough that there's a high of mania and a low of depression, now I'm going to toss in a few more things, a few curveballs that this disorder throws at us. The first one is what is known as rapid cycling. Cycling. A cycle might be considered that full cycle from a normal mood state, a high of mania, a low of depression, and back up to baseline. And in bipolar disorder, we might see just how rapid that occurs. By definition, 4 or more of those cycles within a year is considered rapid cycling. Really, folks who have a lot of that are going to experience 4 of those in a week. And they're going to have these ups and they're going to have these downs. And it's not going to be, I have a high and then I have a low. Remember the chameleon. Some folks are just going to have lots of highs and then maybe a low. Others are going to have lots of lows and then maybe a high. Maybe a few highs and then a few lows. Maybe have a big normal period in between where it's flat, baseline. Different for each person. Remember that when we talk about treatment next week, when we help persons with the disorder understand their disorder, because we're going to help them track that, because that will empower them to understand what is their own cycling like. How do they experience the disorder? So rapid cycling comes into play. It's going to affect us. More things to confuse us. A mixed episode. A mixed episode is a combination of depressive and manic symptoms at the same time. This has been described as the tired but wired feeling. Imagine being, you're tired but you're wired. I feel tired but I can't get to sleep because my brain won't shut off. Someone else referred to this as a despairing anxiety. Right? Again, we got these almost oxymorons here. Despairing anxiety. I'm down, I'm low, I'm despairing, I'm restless, and I'm anxious as well. So I'm experiencing these things at the same time. New to the DSM-5 is just as we're talking about the disorder, we can qualify that there are just mixed features of the disorder. Sometimes, to try and identify, as the DSM would like, a full-blown mixed episode, meeting the criteria for all of the mania, all of the depression. It kind of just says, if we experience some of those highs and lows kind of happening together, these mixed features, let's just call it that. For many folks, we'll see that happening. Again, think of that tired but wired feeling. Then, as I mentioned before, psychotic features. The paranoid and grandiose delusions are the most common. About somewhere between 40 and 50% of folks in a mania will experience those. So just about half the folks are going to experience those delusions. Voices I referred to before, hallucinations, much less likely in bipolar disorder. Probably down somewhere around 15%. Now in schizophrenia, that's going to be almost a hallmark symptom, hearing voices. We're going to see that probably 90+% of the time in folks with schizophrenia. Bipolar disorder, much less common. And also important to know that folks with bipolar disorder, when their mood is in a baseline state, when they're doing well, they will not experience those symptoms of psychosis. As you'll hear about when we talk about schizophrenia, in schizophrenia, folks experience voices regardless of where their mood is at. Regardless of where the mood is at. So here what we're saying is that only in the real highs or the real lows, more likely in the real highs, do we see those psychotic features. It's complicated a little more, because so oftentimes we're not just going to see one disorder, we're going to see other possibilities. With bipolar disorder, and we see, what if someone's depressions are more prominent? It's going to throw a curveball on how we treat the disorder. We have to remember that we don't want to set off in mania, but we have to do things to really address the depression. What if it's schizoaffective disorder? Perhaps that's the diagnosis. Schizoaffective is sort of a hybrid. Persons experience the disruptions of mood, also those disruptions of thinking, the psychotic features, but they can occur even when the mood is fine. They also have manias. So again, it's kind of it's sort of like a catch-all. The person doesn't fit into one, but they seem to have some of both. We tend to call it schizoaffective. Substance abuse. You've got to deal with this. Thankfully nowadays, most programs and most clinics like this one, Pacific Clinics, deal with what's known as dual diagnosis. Dual diagnosis is having a mental health condition and a substance abuse condition. So mental illness and addiction. So maybe we got to treat them both together. We go back a few years and the person would walk into the mental health clinic and like, oh, you got to go get sober first, then come back. If they walk into the drug treatment center, they say, wait, you got some other stuff going on. You need to go to the mental health clinic down the street, get that stuff taken care of, and then come back. Right? They were stuck in that loop. Nowadays, more and more, if not, I would say most programs recognize this and will address both of them. Personality disorders. Beyond the scope of what I can get into here tonight, folks can also experience what are known as personality disorders. Those are more pervasive. They are more likely to have some childhood origins to them in terms of either abuse or traumas. There are some biological components to it as well. But really personality disorders are just, the hallmark of that is the real difficulty interacting with the world in different ways. The term you might hear a lot is borderline personality. A person with borderline can almost mimic bipolar in terms of the real fluctuations of highs and lows. I like you one minute, I hate you the next. I'm doing really well, the next minute I am down in the dumps. So a lot of those real fluctuations we can see. And some of it can almost mimic bipolar disorder. Anxiety disorders. Mania and anxiety can look very similar, right? When I'm anxious, I'm kind of up and I'm amped. And things are going fast. Sometimes I can't slow down. Again, one thing I didn't remind you of is that with an anxiety disorder, again, you will be tired. In mania, you're not tired. Anxiety disorders are very draining. PTSD, invite you back. We're going to be talking about that as we go forward. And then medical conditions. Always good to have if you're early on trying to get accurate diagnosis, just to get a good medical checkup. Thyroid. Thyroid is an important one to make sure you're checking out. We know that hyperthyroidism, one of the effects of that is anxiety. Hypothyroidism, one of the effects of that is depression. So if my thyroid's off, I can be anxious and depressed. I can again have the appearance of perhaps of bipolar disorder. So lots of these things going on, again, that will confuse us. So you can see why it becomes difficult sometimes to diagnose, and certainly becomes difficult to treat. A few other things I want to toss in. First, a word about insight, or the lack thereof. Oftentimes folks with bipolar disorder and schizophrenia will experience what is known as anosognosia. There's your cocktail party term for tonight. Anosognosia, which essentially means, it's essentially a lack of insight. A lack of insight. And Javier Amador has done a lot of research in this, and we credit him with really identifying the location in the brain where we see this happening. And so we recognize this now as a symptom of the disorder, as opposed to what is most often called denial. They're just in denial. They just don't want to accept that this is what it is. And a lot of that comes certainly out of the world of addiction. Right? We know with folks, we hear that word all the time in addiction. The person's in denial. They won't accept there's a problem. Well, with mental illness, what we know is that we can go into the brain and we're going to see that those regions of the brain in the frontal lobe responsible for insight in all of us aren't firing as well. So we're going to see that. So it's a symptom of the condition, not denial. I like to say that folks with mental disorders can be just as stubborn or lazy as the rest of us. But we don't want to just attribute the lack of insight to those things. That's just their personality. Right? They had a personality going into this, they're going to have one coming out of it, just like the rest of us. Right? We can all be those ones. I often say, really should say with psychosis and mania, meaning with psychotic disorder or with a bipolar disorder. And obviously, it probably just makes logical sense. It's going to be one of the most difficult aspects of treatment. Oftentimes it does not respond well to medication. Folks can be very balanced and stabilized other ways, but still not have insight. And the other result of that is, well, if I am not sick, then I don't need help. Why are you suggesting I take a medication when I don't have a problem? So I'll recommend Amador's book by that name, I'm Not Sick, I Don't Need Help. He talks about that and does a great job of helping families understand how to communicate with their relative. And you'll hear more about that in week 7 when we talk about the helpful roles and skills that those family members can take. But I want to at least toss it out here tonight. Another thing I want to just toss out a little bit is a word about anxiety and trauma. In the brain, in each hemisphere of the brain, there is this almond-shaped structure, which is the amygdala. And amygdala is the Greek word for almond. And the amygdala is located in the limbic system. And among its functions, the amygdala is the emotional core of the brain that triggers the fear response, the more commonly known as the fight or flight response. The fight or flight response. And again, this is a good response. This is a protective response that we all have built in. Think about it from an evolutionary perspective. If some danger is approaching me, I want my brain to react fast. This part of the brain reacts fast. Fight or flight is quick. That frontal lobe of the brain that I've referenced is the slow brain. Right? Problem solving, organizing, planning. Now it can do some very complex things, but it doesn't go as fast as this part, because this part works like a snap. So this part's going to override the frontal lobe. And if I'm presented with danger, that's a good thing. I have a lion chasing me on the plains, I want to act quick. I don't want to stop and think about this, I want to act first. That car cuts me off on the freeway, I want to swerve first. and then, oh my gosh, what just happened? I don't want to go, oh my gosh, first, because I might freeze. Emotion now takes over. No, I want to act quick. Think about it later. And that's the part of the brain that does it for me. So it's a really good thing. In trauma, whether it's childhood trauma, adult trauma, certainly going to hear about this when we talk about PTSD in a few weeks, but even the trauma of going through the experience of a mental illness, because that is a trauma for the person and for the family. This is often overlooked, that this is a trauma. The person's experience is like they went through this trauma. Right? You visited them in the hospital. Imagine what it's like going through this. Imagine what it's like going through this when you don't even think you should be there. Right? It is trauma. It's trauma for you as family. What's going on? What just happened to my son, my daughter, my spouse, my sibling, my brother, sister? So when trauma hits, right, we're all thrown off by it. We're all thrown off. And what it does, it kind of can set off this fight or flight response. And it's like we're in crisis mode. Now, if we just have a crisis and we go through it and we come out of it, fine. But when trauma persists, it's going to have wear and tear. It's going to have wear and tear on the body and on the mind. And what we'll find is this short circuit in the system. We'll talk about this more when we talk about PTSD, but essentially, what's going to happen here? Some stimulus comes in, and when this trigger when the amygdala kicks in, because it's been triggered, what happens is there's this kind of shortened route, and I get an emotional response. Whereas, again, the longer route is going up to the frontal lobe, kind of thinking it through and coming down. So, example of PTSD, the vet, right, in war experienced bombs, the noise of bombs going on. When that's happening, got to react quick. Amygdala is a savior at that point. However, persistent exposure to that comes back. We all have heard of the term flashback. Here's a car backfire. Here's loud noises. Same reaction, right? Same reaction. Because now the brain has just gotten accustomed to this, and the emotional response just happens. Right? There's not a stop and think through it, because the brain's saying danger, no time for that. And so when trauma hits, increased cortisol secretion. Cortisol is the stress hormone. Right? So I'm going to be stressed. My immune system starts breaking down, because in crisis, I just need to act. And so other parts of my body are going to shut down. So for example, my digestive system gets shut off when I'm in crisis, because that's not important. It's not important to digest my food when I need just to get away and save my life. So immune system slows down. Again, now in fact, because it's getting overworked, we're going to get decreased autonomic system functioning, so that flight or fight response is now not working too well. That I'm not allowing the frontal lobe to process as well. And in fact, even the hippocampus, which is the memory center, is smaller. Bottom line, chronic anxiety and depression, chronic things. So I put this in there because so oftentimes, whether it's the experience of the illness or traumas the person experienced before the illness, right? If I'm saying we're getting one of the outcomes is chronic anxiety and depression, again, things that kind of mimic highs of mania, lows of depression. It's just going to add to it, add to what we're dealing with, and complicate things for us even further. Again, we'll learn more about trauma in week 6 of our series. We talk about post-traumatic disorder. I'll take a few moments here and talk about the causes and how we understand that of bipolar disorder. And again, what I will say to you is bipolar disorder is caused by an interaction of genetic, biological, and environmental influences. You must have the genetic or biological predisposition in order for the environmental factors to trigger the onset. So environment plays a role, absolutely. Absolutely it's going to play a role. But we have to have some of the biology, some of the genetics underneath. There's too many different outcomes of stress, depending all on bipolar. We're seeing there's some things underneath that are already there. So that's our way of understanding it. To go into that a little more. What are some of these, we say, causal factors, biologically and genetic? We're looking at genetics. We're going to look at brain structure. We're looking at brain chemistry. So the structure is like all the parts of the brain. The chemistry is all those neurotransmitters, how the wiring, how the messages are traveled in the brain. So we have the again, brain structure, brain function. Then we're going to look at these other models called kindling and the circadian rhythm. So let's just go through a little bit of these, give you a little deeper understanding of it. First, genetics. I want to say that really what we're seeing here is a complex interaction of genes and not just one specific chromosome. You know, when we first started doing that Human Genome Project, you know, the hope, I think in so many ways, was we could identify, like, you know, here's where it is. This is it. We found it. But most disorders, what we're seeing is that it's really a complex interaction. And that's why sometimes it's hard to see, like, you know, we can't just perfectly predict with genetics, although we do know as the genetic link is greater, so is the likelihood of developing the disorder. I'm going to start actually on the right side. What we know is that with identical twins, right, identical twins share the same genes, or in a situation where two biological parents have bipolar disorder, we're going to see about a 60% chance that that person will have a bipolar disorder. So it's telling us that this disorder is roughly 60% genetic. Now, lowers pretty significantly. We go down and have one parent with the disorder, or a sibling, even a fraternal twin, and what we're going to see is now we're down into the teens, somewhere in that, in the teens in terms of the likelihood of getting the disorder. A second degree relative, aunt, cousin, grandparent, let's say around 4%, but even no relative, 1% chance of the disorder. So it's saying genetics play a role, but they're certainly not the whole picture. The other part that sometimes we might look at that and say, well, wait a minute, no one in our family has this disorder. You're saying it's genetic, how could that be? It just doesn't quite make sense. And two different ways that this can be answered. One is sometimes, because we know a few years back, we really didn't diagnose this so much. But perhaps you remember how Aunt Martha always did those things that were a little bit peculiar. That back then we just kind of, you know, put up with it, dealt with it. She was okay, nothing that bad, but okay, maybe this is what was going on. But the other side of it is that we don't really need to see any relative with the disorder, because if you remember what I was saying, when it's this complex interaction of genes, we can draw some from the maternal side, some from the maternal side that go in there in terms of that interaction. So it can come from anywhere in that way. And again, even when there's a low genetic probability, we're going to see some of the biological factors that I'll talk about come into play. When we talk about the brain structure, again, we're focusing on patterns and connections in the brain. We might see a few things in our studies of the brain. One of them is something called an enlarged ventricle. A ventricle is essentially a cavity. You know, like we have ventricles in our heart, it's that cavity. And in the brain is not a solid structure. It's more like a sponge. It's a picture of a sponge, right? When you have a sponge, you know, there's air in there, right? There's cavities in there. Ventricles, what we might call those. And in mental illness, what we're going to see is those ventricles are larger than they should be. They're larger than there should be. So what is it saying? It's saying that there's less structure of the brain than there should be, because there's more of these enlarged ventricles. And certainly where those are, and if they're in key areas, going to make a difference. The other thing that we will often see is lesions on the brain. Now, one of the things that happens when you see lesions in the brain is a high likelihood of seizures. And in seizure disorders, we'll see lesions on the brain. And not coincidentally, some of the medications used for bipolar disorder are anti-seizure medications. We'll hear about those next week. Depakote being the most common one. And so again, you know, we're kind of looking at this and we can see these patterns, these interactions. Nothing's that's going to say, aha, this is exactly what it is, or this is what it leads to. But enough that we can see yeah, this is what's going on in the brain. We can see these structural differences in research. Right now, we can't use a brain scan to diagnose the disorder. We cannot use a brain scan to diagnose. Still at this point, the best way to diagnose the disorder is going to be sitting down with a trained professional, identifying symptoms, person getting significant others or family input in that to be able to diagnose. Brain scans can help, they can, but they're still going to be in combination with that clinical assessment. In research, if I'm comparing 100 of these and 100 of those, I can see statistical differences, but even within those 100, I'm not going to diagnose all 100 on one side and all 100 on the other side. So just to kind of point that out, because I know sometimes I start talking about brain scans, and the first question I get is, well, great, can we just do a scan to diagnose? And not yet, not yet. Brain chemistry focuses on the activity of what are known as the neurotransmitters. These are like the chemical messengers, the taxis in the brain. Right? They take messages from one place to the other. When you see a Zoloft commercial and you see that little bouncing bubble, that is a neurotransmitter that they are animating on a screen for you. And we're trying to show you how a medication, which it does, can help with balancing brain chemistry. As a little side note, some years back, probably 50 years ago, around, there was what is known as the catecholamine hypothesis. Catecholamine is one of the neurotransmitters in the brain. And someone found that in bipolar disorder, in the depressed phase, their catecholamine levels were low. And in the manic phase, their catecholamine levels were high. And so it was like, aha, we found the cause of the disorder, catecholamine. Well, over time, what we've kind of realized is that, there's something called dopamine. And sure enough, when someone was mania, their dopamine levels were too high. And when they were depressed, they were too low. And so, okay, well, maybe it's just too much of this chemistry in mania, too low with depression. Then we saw serotonin. And in depression, the serotonin levels are too low. But in mania, the serotonin levels are too low. So again, now the more we understand about the brain, the more, again, we're seeing it's this complex interaction. It's not just one of these neurotransmitters, but again, many of them which interact in the brain. And really, this is one of the reasons probably why medication management can be so challenging. Finding the right medication or the combination of medications. Because everyone's chemistry is going to be a little different. And how it addresses those different neurotransmitters, each medication will do that a little differently. And so to talk a little bit about just the environmental factors. Some of the big ones: stress, substance abuse, major life changes and loss. And again, these will often trigger that first onset of the disorder. Many times I've had someone come and say to me, it was that breakup. I was in this relationship, it was intense, and then we broke up, and that's why this happened to me. So I kind of know what happened and it won't happen again. Or I just overloaded, school got too overwhelming and I had to drop out. But I can go back now. I'll manage it differently. And in time, they're absolutely correct, because in time, that's what happened. But what we're seeing is that those events are actually triggering some of the biology that was already at play. Meaning that part of the reason they were having a problem in school with that semester is because the brain wasn't working as well as it was. And it's starting to suffer a little bit. Or if we see substance abuse, part of the reasons the substance abuse started was to manage some things that were going awry. And so when that final thing happens, sometimes we can attribute it to that. But really, I want to invite you to see it as it was just that last straw. It was the thing that set it off. We know that as time goes on, these things are going to be very important to manage. Stress and substance abuse, good structure, good support. Well, again, we'll hit on those next week, but so critical in managing this disorder, because we know how sensitive now the person becomes to those fluctuations because of what it can do to their mood states. A couple other factors to talk about: circadian rhythm models. Disruptions in the sleep-wake cycle can set off a cascade of dysregulation of brain functions. So, important for all of us, right, to be on a good sleep cycle. Especially important for someone with this disorder, because when that gets thrown off, it can trigger an episode. Right? Not just a bad day. Trigger an episode. We've got to be careful. Folks have been known to arrive at Heathrow Airport in London in a manic episode. Because what happens when you fly from the US to England? You lose that night of sleep. Right? And circadian rhythm is based on your exposure to light. Your body knows this exposure to light. Which is why sometimes just a lot of take melatonin if you fly, right, to try and balance that out. But that's been known to happen because of that. So does it mean that someone with bipolar disorder can't take a night job or do things at night? No. It just means we have to be aware of this. Be aware of this and manage as we go forward with things. The other thing, coming back to stress, is what are known as the kindling models. And that's the idea that multiple minor stressors can build up until the final one leads to a relapse. Think of when that old rub and two sticks together to make the fire, right? You rub, it gets warmer, and then finally get that spark. Right? It built, it was kindling. That's what kindling does. So it's kind of like little, but you only see it when it finally hits. So multiple things lead up, and you get to that point of relapse. So let me just kind of put together what we've been talking about tonight, and maybe a little teaser for next week, and then I'll open to some questions. So what have we said? We've said that bipolar disorders are biologically based brain illnesses with strong genetic factors. We've said they're characterized by mood swings. We talked about the highs of mania as well as the lows of depression, and we talked about some of those other complicating factors like rapid cycling and mixed states and things like that can complicate the picture. We've said that these are equal opportunity disorders. Equal opportunity disorders exist in 2 to 6% of the population worldwide. And again, I'd like to really underscore when we've talked about the biological basis of it, this equal opportunity of it, this biological course, the average age of onset, all of those factors to help underscore this. And I'm also trying to underscore my attempt to destigmatize and hopefully alleviate you of some of the guilt that you might have walked in feeling around this disorder, because I'm sure at some point in time, maybe more than once, you've been blamed for this. And so I really want to emphasize this knowledge with you. There is no cure, right? It is a recurrent disorder. However, there is recovery with the treatments that can improve the quality of life. Next week, we're going to talk about 4 pillars of treatment. We're going to talk about medications. We're going to talk about the psychotherapy approaches that are helpful. We're going to talk about the importance of support and empowerment, so family support or friends, peer support, that kind of empowerment as well. And then fourthly, just some of the lifestyle things, lifestyle practices. Things that when we talk about those are stuff we can all benefit from, but when it comes with bipolar disorder, these become important parts of treatment and managing the condition, and managing them. So we're going to look at those 4 pillars. And again, we're going to be joined next week by Erin, who's going to describe her experience of the disorder, and also be very open to taking questions and how she came around to getting treatment, getting good treatment, struggles with that, and kind of coming back where she's been in a pretty good place in terms of being able to be a teacher and go forward and get married. And so it's just a delight to hear her story and a real inspiration. So that's where we're going to be heading next week. So that's my little teaser to get you to come back, hear all about the treatment, the things we can do about the stuff that I've been talking to you about tonight. So with that, let me pause, and I'm just going to open up for questions you have. Yes, ma'am.
Dr. DiPaolo, can you tell me your theory on fixed delusions? Maybe you'll be discussing that later on, but my son seems to have the same delusion every time he has a psychotic break. And now, over a period of 20, he's now 40, the same delusion keeps coming back.
Yeah.
Do you think that delusions with psychotic breaks change, or are they mainly fixed?
Great question. The question has to do with delusions. Delusions are those false beliefs that will be held despite what others around would say, and even evidence to the contrary. And the question of them being fixed, which essentially we'll see a lot, where the person has a delusion, maintains that delusion, over time it doesn't change. Perhaps they can have periods of time where things are okay and it's not really there, but other times it kind of comes back really strongly. And typically it does. Typically the theme within the person is going to stay there. It's going to stay there. So if my thing is the CIA is bugging me, putting bugs in because they want my information and knowledge, that's probably what's going to come back. Something around that. It might change a little bit. Maybe it's not bugs in there. Maybe it's people that are following me. But still along that same theme, I think is generally what it's going to be. There are going to be cultural differences, like I mentioned earlier, in how those delusions will play out. I believe also that there are certainly personality characteristics that can play into that. From a practical standpoint, though, that's necessarily going to help me because we're not going to be using insight into trying to understand these or help the person understand them. Some folks with a higher level of insight and awareness, sometimes we can do a little bit around those themes of the disorder, about why for them the world's a scary place and some of those fears, which on a good day are just mild, but on bad days are fully psychotic. So in some cases we can get at that, but by and large, yeah, they're going to be fixed, and they're going to be there. And the other thing I'll just say about that too is that, and this is probably more with schizophrenia, but oftentimes in dealing with those, when persons are doing well, they're just not thinking about it much anymore. But if you ask them, they probably still believe it. Meaning that sometimes, when I'm at my worst, yeah, the CIA is doing this, and I got to do all these things to protect all of that. When I'm in a stable place, I'm not really thinking about it. But if you came up to me and said, "Do you think the CIA is really?" Yeah, they are. But I'm just not focused on it. So we don't need to push that way when that happens. I'll let it go.
Under the biological factors, I found that it was interesting that brains can identify the enlargement of bipolar delusion, but do you have any concept of what would create that in the brain?
I'll give you the general answer because I don't have the real specifics to it. But a lot of the biological differences would probably be happening in utero. So there's just things in the brain development in utero that might be happening. And sometimes, again, through no fault of something. We're not just talking about because someone was using drugs in utero and causing problems, but just things that occur. Environmental stressors. We'll see, for example, I think winter birth is going to be a higher likelihood. Now again, statistically, when you're looking at from this much to this much, wow, it doubles, but compared to like this, it doesn't look like a lot. But from a research perspective, okay, there's something about it that's happening in there. So a lot of it will probably be in utero. Sure.
With all of the talk that you have done here, I'm thinking about one thing is that starts when they are 15. And I think in NAMI and other things, we have to do something in school. Because most of the problem with the parents is that they do not accept that their children has problem in school. And they blame the teacher, and they blame the other. And for me, the best thing to do in that time is to take your child, look at him and say, he's sick. And go with him to a doctor when it's time. Because it's not time to go to a doctor when he's 13, 15. It's when he's 15 to 17 that he'll come and see you. And then you could help him. Because you are in charge at that time to give them the medication. And to sit on them if they don't take it. If you are a good mother. Thank you.
Thank you for that. I think at whatever age you start to see something, the idea is we're trying to address it. Try to address it early. Oftentimes, and again, that chameleon and why that statistic of it taking so long to get the right treatment is because sometimes in childhood adolescence it can be something else. It's not necessarily bipolar. It doesn't present as that. It looks like ADD. It presents as ADD. That's all we're seeing. A lot of overlap with bipolar disorder and ADD. I don't work with children, but it's just a lot of confusion in trying to differentiate between those two. but sometimes it is ADD and then later becomes bipolar. So again, it is very confusing, but certainly the bottom line, yes, if you see something, to try to address it sooner than later. Any else? I have time for one more question, if there is one there. Yes?
Just real quick, I'm dealing with a 16-year-old after this. Is this something, the slides, something you share with them or you stay away from that so they might have a better understanding of what's going on with them and why they're...
Great question, great question. The question really is this good information to be shared with your relative who may be suffering with disorder? So your daughter was 16, and the first answer to that question is, or the first factor to consider in answering that question is, where is the person at? If someone is fully accepting this is what's going on, education is empowering. It's very empowering. Some folks want to know information about it. Others don't want to know all the stuff about it. They just want to know what to do. Fine. If there's not that insight or not the acceptance, this will tend to promote more conflict and distance. And so we wouldn't want to present it. Same thing applies. Sometimes persons with disorder will come to these and really get a lot out of it. Other times, it's the last thing I'd invite you to do because all you're going to do is promote more conflict and distance. So it's really going to be dependent on your relative. And if you're somewhere in the middle, you might just ask. Do they want to learn more? That's what it is. Here's a few of the handouts. Or here's some, same thing with a book or a website. Do you want to learn more about it? And explore it that way. Yeah.
You mentioned ADD. Can you talk a little bit about the difference, if any, between hypomania and some of the laser-like focus? Because ADD, people are knowing, is just distractible. They can also pay attention to things.
Yes.
How do we tell the difference of these?
Yeah, that's a great question. And again, usually it's going to be more, because we're going to see this problem more in childhood. With bipolar disorder, again, we're probably going to, we will see the disturbance in mood. So in ADD, we're typically seeing the things you were just talking about. We can see the distraction, but also that laser-like focus, that real zoning in on things. With bipolar disorder, we're going to see those mood fluctuations. We would probably say we'll see more of the irritability and things like that. Although you're going to see some of that. I mean, kids in adolescence, some of this defines it going through adolescence, some of these things we saw here. So it's really complicated. Not working with kids, I've kind of shied away from having to deal with that problem too much. Because in adults, it's usually a little bit easier to kind of get at if there are mood things going on. And they can describe them a little better. Kids have a harder time doing that. But there is in terms of some of those attentional things, they're going to be the same. They are the same.
You just mentioned hard with kids. Don't ADD kids grow up to be ADD adults? I mean,
yeah.
Magically go away? Or?
Yeah, no, they do, yes, absolutely, absolutely. Just saying that if I was assessing an adult, usually you can be more forthcoming and describe moods and things like that. Your seven-year-olds can't really do that so well. You just get the behavioral issues. You're trying to figure out from there. So with that, again, I want to thank you all for being here tonight. I thank you on behalf of your relative for being here tonight. And again, look forward to seeing you next week when we talk about some of the great treatments for bipolar disorder. So thank you.